was a lot more anxiety provoking when we were doing that, because we had no idea what the causative agent was. We were going through all sorts of different possible viruses. And that was the first time a coronavirus had really infected humans, to my knowledge.
Dr. Langer, do we see sometime during the next 3 years that when you're filling out an insurance form, the agent is going to say, well, did anybody from your family die of COVID? Did you have COVID? Are you therefore a higher risk? Can it potentially cause cancer?
I'm not aware of any evidence that coronavirus has increased the risk of any kind of cancer in the future, no.
So no viruses in general don't cause cancer?
No, I didn't say that. The coronavirus was your question.
Right.
So yes, there's a role for certain infections in certain types of cancers, but this respiratory virus is not known to cause cancer. This group of viruses is not known to cause cancer as far as I know.
Somebody sent me a video of somebody who has the virus, or actually it was a doctor, it was a respirologist, and he said that breathing exercise, if you have COVID, don't stay in bed hunched up, get up and force yourself to walk. Is there any proof of that?
As far as proof, there's no proof of that. It's logical that, you know, one of the ways there's a couple ways that the virus affects the lungs, and one of the ways that the ventilators are designed to work is by opening up airways that won't otherwise open up because of the virus. Another way that it's less successful is when those airways, the airways at the end of the bronchial tubes called the alveoli, when those sacs are filled with fluid. It's not very helpful and the prognosis isn't very good. What the respirologist is talking about is addressing the former issue, which is by taking deep breaths, you expand your lungs. So someone who's had broken ribs and they're in the hospital, the nurse will come by and 3 times a day, or the respiratory technician, and get the patient to take deep breaths, because otherwise you're not expanding all your airways and they're going to fill with fluid and it's going to increase your risk of pneumonia. So I saw the video that you sent me from the respirologist, and so he's trying to address that, saying if you get early symptoms, start taking deep breaths, do unusually deep breaths, forced coughs, etc. The idea is to keep your lungs expanded. And while that's logical, I'm not sure if it has any preventative value. And when you are infected, I imagine that there would be some, and it's causing airways to collapse at that point, which is not going to happen with the mild cases. I'm not convinced that it's going to make a significant difference. It's certainly something that I would encourage someone to do, or they have these things called incentive spirometry, where these machines, you may have seen them, when you blow into them, you have to, and make the ball go up, and so you have to really fill up your lungs. And that, once again, that's the idea, so that your airways are all open up. But it's a simplistic notion to imagine that it's going to have a significant impact on the disease in terms of its outcome is hard to imagine. The end.
Now, one of the things that we try to do is to try and avoid people having to be on the respirators. We initially, the data I had got was that people did well on the respirators, but unfortunately, 60% of people who get on respirators do not get off of them. And part of that is there's some thoughts that the lungs are acting differently from the typical viral pneumonia. And so we shouldn't be using as high pressures and other things. And so things to do to keep people healthy for as long as possible, and just give supplemental oxygen if possible is much better.
I don't, this is questions both of you, whoever's more comfortable in answering it. You can
Ron.
go fight it out if you want. And I mean by saying, no, you please, no, you go ahead, not insisting on it, but how are we doing with flattening the curve? At what point can we measure and say, okay, it's happening?
So I was actually looking at the projections from the Ontario model, and they're actually very happy with it. So what they had projected for the end of April was about 80,000 cases in Ontario, and we're at 11,000 cases. The curve is definitely flattening. It's not going down yet, but it definitely is improving. And the models show that it's definitely, we're close to the peak if we're not at the peak now. And hopefully by the end of May, will be much lower in number of cases, and hopefully not using that much medical care at that stage.
Yeah, I agree. It looks like we've at the peak. We can't let our guard down, because that could change, and so it plateaus for usually for days as opposed to weeks, in my understanding, and then it starts to go down. So, God willing, with continued vigilance, we're not going to see the kind of number of people on ventilators, the number of people dying, like we are seeing. It's going to be skewed by the fact that now more and more testing kits are available, so more people are going to be tested. So what's going to look like an increase in number of cases may not actually be. But to the extent that we're analyzing the data based on a similar number of testings, the numbers are definitely, the acceleration is slowing down and flattening, and it's happening now.
And the way public health looks at the data is they look at death rate and hospitalizations in ICU visits. And so that way, those are numbers which don't get skewed by the testing.
Okay, I'd like to open up the questions. So if anybody has any questions, you can go ahead and unmute yourself, and I'll put you in line for Dr. Langer and for Dr. Phillipson. Dr. Langer, have you treated any patients with COVID?
No, I have. I've had a couple of patients who had it. They had it mild, thank God. And but no, I haven't.
Akiva?
Okay. Yes, go ahead, Dr.
Okay.
Goldhar.
Lorne and Ron, how are you guys doing?
Good, thank you.
We're hungry.
Excellent. Just a couple of points. Just to share with other people, there's also, they're finding that there's an increased incidence of kidney disease associated with COVID, and that's starting to give some problems, and it's also starting to make people think in terms of the ventilators. So the ventilators may or may not be associated with the kidney disease. But just a point of information. But what I wanted to ask is, it's interesting, this last point that you brought up, that the incidence of COVID infections in the province seems to be much less than was projected, which the flip side of that is that the number of people who are still susceptible is probably a lot more. Which means that in terms of the duration of isolation, And B, when they start undoing the isolation, are we going to see, or do you suspect that we'll start seeing a second blip in terms of the incidence of the infection in people who have not been infected or not been exposed?
I think the answer to that question is it's an excellent question, and they're going to see what's happening where it all started, because now in China and Wuhan, where it all started, now they've loosened the reins, and they're monitoring what kind of recurrence rate is happening there, and that will inform how we move forward. But it's an excellent question.
And do you think that there'll be also a recurrence of this, barring the appearance of a vaccine, next fall, winter time?
Seems to be certain, and I think the goal wasn't that we weren't all going to get infected by isolation. The goal was that we were going to all get infected in a more manageable rate, and that's what likely is going to happen. Also, as the good weather comes, that has an impact on respiratory viruses, and that will help as well. But yeah, this is, people who know a lot more than I do are certainly predicting that this is, barring a vaccine, this is going to be around for a year or two.
What's your, one second, Rabbi Weinberg,
Yeah.
you have a question, go ahead.
I just want to know if the anti-malarial drugs are showing any sign of effectiveness.
Ron, your turn.
That's so convenient.
We need
Smooth.
the studies to show it one way or the other. There's a lot of anecdotal proofs that it works, but medicine has a long history of snake oil and other problems. And so until we actually have the studies to show that it works, there are definite possible harms from the anti-malarial medications. So they're not recommended in Canada. In fact, the college came out quite strongly against it.
Thank you.
Schmoozes. Who's schmoozes? Go ahead.
Moshe Rand, how are you?
Who is it?
Moshe Rand, how are you?
Oh, okay. Go ahead. You're a Kohen. Go ahead.
Question is this, based on the information that's coming out, first of all, there's so many different varieties that are coming up with this coronavirus. It's not just changing to different things. Some of them may have that goggle repeat, things like the white blisters. Some of them continue to the lungs, some of them continue to the heart. There's so many different varieties. The question is, how do we know which variety we have here? I know in the U.S., Eastern United States has one variety, Southern United States has a different variety. But what do we have here? Is in Canada the same thing? Some provinces have one variety, some have another. But each one would be completely different. That's what's going on right now. That's what's going on.
Ron, were you able to hear the question?
I heard part of it. Basically, what you were asking was there are certain strains of the coronavirus, and I don't know which strains we do have, but the way they do the testing for the coronavirus is they do PCR testing. So they do a nasal swab, and then they grow copies of the virus, and they can tell using different markers which strain it is, but I have no idea which strain we have.
But I'm saying in the U.S., they said the Eastern United States has one strain or one mutation, and Southern United States has a different mutation. So actually, and in Europe, supposedly Canada and Europe has the same mutation. It's that different.
I can't hear him. I hope that's not a symptom of COVID.
Yeah, I think he was saying that the Eastern United States, it seems to be a completely different strain than it is in Southern United States, and it's a third strain here. Is that feasible? You think it's the same strain?
No, I didn't say that. I just said it's news to me.
A lot of these viruses do undergo some mutations even during the time that they have. So it's a possibility that you're getting slightly different strains, but the basic virus itself is staying the same. So you're just getting minor variations, which are really not affecting things too much.
It causes different reactions. Each strain causes something else different.
It's probably more the genetics of the person that are doing that rather than the virus.
I don't think anybody can say say definitively that these different strains are causing different symptoms. Nobody knows that.
Yes or no? Okay, a Samsung Galaxy S7. You have your hand raised. You're not identified. Go ahead.
I have two questions. Question number one is, I read recently that another symptom of the COVID virus that's coming to light is sores on people's feet. I'm just trying to understand how a respiratory virus affects feet. And the second question I have is more broad, and that is, I'm not asking for a timeline, but what technically does the government, doctors want to see before we start relaxing this quarantine? Which is really what Mechi Wurzburger asked earlier.
Yes.
In terms of the first question, maybe Johnny wants to put in his 2 cents. He probably knows more than I do about it, but my understanding is that you're right, that especially in pediatrics, that there are lesions on the toes. I think it's a form of vasculitis, an inflammatory condition, probably autoimmune, of the tiny blood vessels that supply the digits. And as far as how does a respiratory virus do it, I don't know the answer to this particular virus, but it's an immune reaction usually, where the antibodies, the body fighting off the offending agent, the virus, ends up combining with the antibody and antigen combined together. They create an inflammatory response, or sometimes a vasospastic response, a spasm of the little arteries. But just like you'll see with autoimmune conditions, lupus and otherwise, where you'll see vasculitis, which manifests in rashes, and Raynaud's phenomenon, other things, you can get it as a response to infection. But again, I'm happy to have my colleagues speak to it if they know more than I do.
It's basically a form of pernio. That's the official term for it. What happens there? It's to a certain degree vasculitis, or can do that. But sometimes you'll just get some blockage of the vessel, so a slowing down of the blood, or a sludging of the blood in the area without vasculitis. The thing tends to disappear in about usually about 4 or 5 days. So it's probably the latter, although the vasculitis could be associated with it. But one would really suspect that to last a little bit longer if it were true vasculitis.
Yosy, I hope it answers the question. We have 2 minutes left.
That's the first question. The next thing I'm looking for is what medically is the medical community looking for before the quarantine is relaxed? Are they looking for everyone to get it? Are they looking, I don't know, what can we look forward to? And again, I'm not looking for a timeline. I'm just looking for technically what they're looking for.
So the World Health Organization has come up with 5 criteria. And I think basically what those criteria are is having surveillance so that you can catch cases very quickly. You can do contact tracing and isolate all of those contacts. And you are able to prevent new cases coming into the country. And so in those cases, then you can relax the social distancing, because you'll be able to catch cases quickly and prevent major outbreaks occurring.
Okay, I have one. Go ahead.
Sorry.
Ravi, go ahead.
No, I was just going to, because you were talking about before the second wave, then you talk about we're going to look to Wuhan, and that was what Ron was just saying. are we going to have to expect that we're going to take over those draconian monitoring measures in order for the medical to achieve those kind of results? I mean, if you looked, I mean, I don't know, I saw a video of what they're doing over there. And I was wondering if that would ever fly in North America, or would that, can you actually, I mean, I know it's not a medical question, but is that actually what's going to happen in order to achieve those kind of results?
I don't think so. I think that that would achieve the results faster, but that, as you point out, at a cost that we, as a society, have to determine whether it's worth it.
Just want to point out one. Just want to point
Yes.
out. I'm a little bit, and I remember as a kid polio, and we were basically in the same position with polio as we are here. I remember having to isolate everybody. They cut off all social, until the polio vaccine came out. This was, I remember as a kid going through all of this.
Okay, we have literally 2 minutes left, and I want, if the Rav is still on, to give them a bracha. Last time, which was 3 weeks ago, Dr. Ron suggested that we work on our relationships. So I'd just like Dr. Ron to know that the relationship that I have now with the fridge in my house, as well as my pillow, has never been better. And ironically, you explained to me that the word pandemic comes from where?
From panda.
Panda, which means?
So pandas eat between 12 to 14 hours per day.
Okay, so I'm living up to that. Is the Rav still here? Yes. Is the Rav here? Yeah,
Yes.
Hi, Rabbi Lo. If you can just give the bracha to the doctors to continue
the
their
doctors
work.
are the ones that we have that they're in the front line of, and they're putting themselves in skana. And, you know, like, you know, there's all those protesters who are protesting, and they don't realize that you have all these workers who are in the health and the front line, and put mamish, many Nebuch in all these places, doctors and nurses, and all the ones who are helping. And so I give a bracha to the doctors, all the doctors, wherever they are, and all the health caretakers, and anyone who's involved, even people in the grocery stores. No, I mean, they put themselves in skana, and they're doing it just because they know you have to eat, and you have to. I'm sure that all the Reifim the Malach Rafal should be with them, and they should be gesund and stark and have Riches Yomim, Meshonim. All the frontline workers should all have their banshim, should give them a schus. The schus, what they're doing, I'm sure they're going to get the big chelik in Al Mabah, but they should also have a chelik in Al Mazeh. They should be able to live and continue to help people after the virus leaves, and should be able to keep him healthy, and all together we should be zeicha to see Mashiach Meher B'Yameinu.
Amen, amen. Thank you to the Rav. Thank you to Rabbi Philip, Dr. Ron Phillipson. We're still waiting for the Divrei Torah that you promised last time that you would kick up again. And Dr. Lorne, I hope you get a new calendar so we can tell the days of the week. Thank you so much. Take care. Everybody can give a big Yasher Koyach.
Take care.
Thank
Bye,
you.
everybody.
Thank you.
Thank you.
Thank you, Dr. Ron. Thank you, Dr. Langer. Thank you, Dr. Johnny.
Thank you.
Akiva.